Hello, my name is Dr. Seremi Ibadin, a research associate with the Department of Community Health Sciences at the University of Calgary. I'm joined by my co-author, Dr. Suqing Lee, a therapeutic endoscopist with the Department of Medicine at the University of Calgary. On behalf of all our authors, we're grateful to GIA to have the opportunity to discuss our recent paper, The Development and Usability of an Endoscopist Report Card Assessing ERCP Quality. To start our discussion, let's talk about the motivation behind the study. What led the research group to feel the need to create an ERCP report card? Was there a particular gap or challenge you observed in the current standards?
Yeah, thanks, Seremi. So, despite the advancements and the rapid growth that we see in ERCP since it was first developed in the 1960s, contemporary studies have shown significant variability in quality measures between facilities and practitioners. We know from the colonoscopy literature that audit and feedback tools such as report cards, developed using well established quality indicators, can be quite valuable in providing endoscopists actionable feedback and helping to boost procedural quality. Now, given the success that we saw from colonoscopy, we saw promise in the use of audit and feedback report cards for ERCP, but felt there were significant gaps in the current literature that need to be explored. To date, only one study that we have found at least had looked at developing ERCP specific report cards, and this study did give valuable insight in the feasibility of generating report cards via mandatory structured data fields. However, the report card itself was based solely off of quality indicators developed by the ASG and ACG and utilized self-reporting, which can generate significant bias. Now, the ASG and the ACG quality indicators by all means do represent very important parameters that should be included in report cards, but compared to procedures like colonoscopy, the data that were informing these indicators was based on relatively low quality data. So our group felt that a study was needed to firstly develop an optimized report card based off of both the recommended quality societal indicators as well as contemporary high quality data. And secondly, and most importantly, to have the report card itself undergo initial usability testing to determine how implementable and acceptable it would be amongst ERCP practitioners to provide an endoscopist focus tool that would bring value to the endoscopist who would actually be receiving it.
Yeah, thanks, Su King. Could you elaborate on what our study contributes to the existing body of knowledge on ERCP audit and feedback?
Yeah, of course. So as mentioned, the existing literature on this is surprisingly sparse as it pertains to ERCP. This likely reflects the difficulty in developing a one-size-fits-all audit and feedback tool due to the significant variations and nuances of the procedure amongst the numerous pancreatic and biliary indications. Now, our study, however, hopefully adds a few items that we felt may help progress the development of an effective audit and feedback tool. So for one, we began the development of the report card on a clean slate and went beyond relying solely on the societal quality indicators to base the report card. So in addition to the ASG and ACG quality indicators, we also conducted a thorough multivariate regression analysis of over 3,000 patients from our own registry to provide some primary data to inform report card parameters. In addition, used findings from a prior systematic review and meta-analysis published by our group to inform these parameters as well. Thus, each parameter that was included was based off of multiple data sources with the most contemporary evidence that was currently available. Most importantly, though, we felt that the findings from our usability testing was the most important to assess endoscopists' perceptions on the acceptability, the appropriateness, and the feasibility of the tool in their own practice settings. So we know that the implementation of any audit and feedback tool can be met with many barriers in clinical practice. So we felt that it was, as much as it was important to develop a report card, it was more critical to identify the priorities, the incentives, and the perspectives on the adoption of such a tool by the endoscopist that this intervention would be targeted towards to ensure a positive psychology of change. So through our semi-structured interviews with ERCP practitioners, we noted several key findings. For one, endoscopists felt that certain granular parameters were quite important to be included to help guide key solution information, such as the rate of unintentional pancreatic duct cannulation, because this would help them provide specific actionable feedback to make the report card more useful to the practitioner. However, other parameters, such as double guide wire usage, for example, was felt to add very little actionable information, as it could change depending on the implication, as the implication could change depending on the context. Now, along this line, inclusion of patient-reported experience measures, for example, was also acknowledged to be, although important as a concept, provided very little actual information and actually may result in more confusion, at least in the current state of the matter. Most importantly, though, endoscopists indicated that although there definitely was a potential that some of their peers may be apprehensive in supporting the implementation of such a report card, the majority welcomed the report card as a valuable and effective tool in improving ERCP quality, and would personally be at least expressed that they would be very eager to incorporate this into their practices.
Yeah. As you described, our work has laid a foundation. What do you envision as the next steps? How do you see this report card being implemented in clinical practice or evolving?
Yeah, so the natural next step would be to implement and externally validate this tool through prospective multi-center studies. I suspect that real-world testing would bring further insights and refinements and changes that we'll need to make to the tool. But ultimately, the hope would be that this tool would then be tested in a trial setting to assess its potential impacts on patient outcomes and quality measures. However, a key limitation that would need to be addressed is the feasibility of implementation of this tool on a large and standardized scale. Many of our ERCP interviewees expressed that due to the granularity that was needed to inform some of the fields, as well as the preference to rely on self-reporting to decrease bias, it would be quite challenging for institutions to implement this on a large scale, especially if they don't already have independent observers for each procedure. With that being said, we've seen a rapid progression in the use of both routine video recording software in endoscopic procedures, as well as the use of artificial intelligence in medicine. So it's not difficult to envision, hopefully in the near future, having AI algorithms interpreting live recordings of ERCPs and automatically tracking relevant quality parameters to generate these report cards.
Thanks for those insights, Suqing. It will be very exciting to see what the future brings. Based on our paper and our discussion today, I think we can conclude that our study has provided the first steps towards the creation of a robust, endoscopist-focused, evidence-based ERCP report card. Further work to validate and incorporate the use of evolving technologies such as AI will be needed to properly implement this report card on a large scale. But the routine use of audit and feedback interventions like this report card will be a key part of improving patient care. Thank you very much.
Yeah, thanks, Seremi. Thank you.